Welcome everyone. The topic of discussion today is tympanoplasty. So the broad headings on which I will be talking about are definition, types, the grafts used in tympanoplasty, what are the goals of the surgery, indications, contraindications of the surgery, and finally I'll try to explain the steps as well as the use of the common instruments used in tympanoplasty with the help of a video. So coming to the definition, what is tympanoplasty? So tympanoplasty is a procedure to eradicate disease in the middle ear cleft and to reconstruct the hearing mechanism with or without tympanic membrane grafting. Now the construction of the definition is very important here because eradication of disease has been mentioned first. So it is the primary goal of the surgery. You always have to mention eradication of disease first, then it is a reconstruction of the hearing mechanism. And why has it been mentioned with or without tympanic membrane grafting will be better explained when I mention the types of tympanoplasty. So coming to the types of tympanoplasty, first I'll describe the classic Woolstein classification of tympanoplasty. Now the original Woolstein classification had only 5 types of tympanoplasty mentioned in it. Later on there have been a few modifications of the classification. So now there are 6 types of tympanoplasty in the Woolstein classification. So I will come to them one by one. So coming to type 1 tympanoplasty. Now in this case the disease has only affected the tympanic membrane and maybe a part of the middle ear mucosa, but all the 3 ossicles, that is malleus, incus and stapes, are intact. That is when we will be performing type 1 tympanoplasty. So what is type 1 tympanoplasty? Now it is repair of the tympanic membrane, which is called myringoplasty. So repair of the tympanic membrane is called myringoplasty. Along with that, we have to remove whatever disease that is present in the mucosa. Mind you, the disease has to be very limited. Only then we can perform a type 1 tympanoplasty. Now there is a bit of a controversy over here. Many books mention type 1 tympanoplasty to be myringoplasty. Now since there is a very big confusion here and more people lean towards what I am going to say, so it is better you say that type 1 tympanoplasty is different from myringoplasty. How is that different? So myringoplasty is only repair of the tympanic membrane, and along with that, if there is a limited mucosal disease, we are removing that, or even in type 1 tympanoplasty we check for ossicular integrity. That is, we are performing something in the middle ear cavity proper. So we are doing something more than just repair of the tympanic membrane. So that is type 1 tympanoplasty. So myringoplasty with limited middle ear work. Now here the important thing to note is, I mentioned before only, malleus, incus and stapes, all the 3 ossicles are intact. So this would be your malleus, this is your incus, and after that there is stapes. So this is the oval window, foot plate of stapes and oval window. So since all the 3 ossicles are intact, the graft will be placed over the malleus here. So this is where we will place the graft. So this is type 1 tympanoplasty. So what is type 2 tympanoplasty? In type 2 tympanoplasty, now the disease process has already involved the ossicles. So in this case, when we will be performing type 2 tympanoplasty is, the malleus has to be eroded completely or partially eroded, and the incus and the stapes both have to be present. Now, type 2 tympanoplasty is very rarely performed because if you remember in my video of chronic otitis media, I had mentioned the commonest, the first ossicle that usually undergoes necrosis in chronic otitis media is the incus, more the long process of incus. So it is very rare that the incus will be intact and the malleus has been eroded. So only in those cases we can perform type 2 tympanoplasty. So that malleus has to be partially eroded or completely eroded. So suppose the handle of malleus is eroded and this is the head of the malleus. This is the incus which should be intact. Then comes the stapes. So in this case we can perform type 2 tympanoplasty. What do we do? Again, after removal of disease from the middle ear, we may remove this malleus remnant or we can even keep it, and the graft will be placed over this. So vibrations on this vibration will be transmitted to the oval window. Now, whether we remove the malleus remnant or not, it is type 2 tympanoplasty, and since we are placing the graft on the incus, this procedure is also called myringo from tympanic membrane, incudo from incus, pexi. Pexi means to join. So myringo, incudo, pexi is type 2 tympanoplasty. So coming to type 3 tympanoplasty. So in type 3 tympanoplasty, the malleus and incus have been involved by the disease process. Now, so the malleus and incus have to be removed. The disease may involve the stapes suprastructure, but the stapes arch has to be disease free. So what happens is, so malleus is absent, incus is absent, so what you are left with is at least the stapes arch and the foot plate on the oval window. So here both malleus and incus are either absent or they are involved by disease process. We have to remove them completely, and the graft is placed directly on the stapes suprastructure here. So the graft is placed on the stapes suprastructure. So type 3 tympanoplasty is also called myringo stapediopexy. Myringo from tympanic membrane, stapedio from stapes, and pexy means to join. So now type 3 tympanoplasty is more commonly performed in our day-to-day practice because whenever we perform a canal wall down mastoidectomy and with a and the stapes disease involving the stapes suprastructure occurs way later in the disease process. So this is more commonly performed, type 3. So the graft has to be placed at least on the stapes arch. So coming to type 4 tympanoplasty. Now the important thing here is I'll try to explain type 4 tympanoplasty along with type 6 tympanoplasty because these two surgeries are very closely related because they are performed in a similar way. So first, what is type 4 tympanoplasty? Now the disease process has involved the stapes suprastructure as well, but the stapes footplate has to be present. So the disease has involved every ossicle except the stapes suprastructure. So what do we do is, suppose this is your middle ear cavity. This is the oval window on which there is the footplate of stapes, and this is your round window. So what happens is, now the footplate of stapes is present. We have to exteriorize the footplate. What do we mean by exteriorize? The footplate of stapes will be totally exposed to the exterior. So this is the direction from which the sounds will be coming. This will be absolutely exposed to the exterior. We'll cover the rest of the middle ear cavity with a graft. So the placement of the graft will be somewhat like this. So this is a type 4 tympanoplasty. The graft is placed on the stapes flute plate over the oval window, but this has to be exposed to exterior. Then coming to type 6. What is type 6? This is your middle ear cavity. This is the, now type 6 has to be performed again, the criteria has to be same. Like in type 4 situations only we can perform type 6. Maybe we can even try in cases where the disease has involved the stapes footplate as well, but those come out to have poorer results. So this is your oval window with the footplate or stapes, may or may not be present in this case, and along with the round window. So what we do is, we'll now exteriorize the round window, but the oval window and the footplate, if it is present, will be covered with the graft. So the round window will be exteriorized, so the placement of graft will be somewhat like this. Now, so this is type 6. Now, this procedure is also called sono-inversion. So why is type 6 tympanoplasty called sono-inversion? Now, to explain that, we have to come to the anatomy of the inner ear, basically the cochlea. So I am not showing the absolute anatomy, like I am not showing the turns of the cochlea. So behind the oval window, where the perilymph circulates, this is your scala vestibule. This is your scala media, and this is scala tympani. And the scala vestibuli and scala tympani are continuous with each other at the helicotrema. So similarly on this one as well. Now, normally the sound vibrations fall on the oval window. So the vibrations generated in the perilymph travel from the scala vestibuli through the helicotrema towards the round window. So this is the direction of movement of the vibrations in the perilymph. In type 4 tympanoplasty, where the normal anatomy is maintained, normal movement of the vibrations is maintained. In this case, what is happening? Because we are exteriorizing the round window, so what happens? The vibrations first fall on the round window. So the vibrations of the perilymph, the direction of movement of vibrations will become opposite. So since here also and here also, here the round window is not vibrating from outside vibrations, and here the footplate is not vibrating from outside vibrations. So the phase difference is created in both. So the vibration of the basilar membrane is same in both the cases. But since the direction of vibrations in this type 6 tympanoplasty is reversed from the normal anatomy, so we call it sono-inversion. Basically, the direction of movement of sound is inverted. Coming to type 5 tympanoplasty. Now, type 5 tympanoplasty can be performed when the disease process has absolutely involved the footplate of stapes, and you cannot generate any vibrations via the oval window side. So basically, to generate oval window vibrations, what we do is, suppose this is the lateral semicircular canal bulge in the medial wall of middle ear cavity. So we'll make a very small hole in this lateral wall of the lateral semicircular canal. So what will happen is, since this is a small hole, we also call it a fenestration operation. And now the graft will be placed on this, based on this fenestrum. So what will happen is the perilymph vibrations will be generated via the perilymph of the lateral semicircular canal. So the vibrations will be generated in the perilymph. We are bypassing both the oval window and the round window, which are involved by the disease processes. But we are generating perilymph vibrations, so the basilar membrane will be vibrated. Now, what is the most difficulty we face while performing this surgery? Nowadays, type 5 tympanoplasty is almost nowhere performed because this is basically to reconstruct the hearing mechanism. But what happens is, while performing the fenestrum, we may injure the lateral semicircular canal so much that there may be a formation of a permanent perilymph fistula. So the perilymph will start to gush out from this fenestrum. So what will happen? The patient will develop intractable vertigo postoperatively. So that is a very morbid condition for the patient. You would be better off prescribing a hearing aid for that patient and performing a type 3 or even type 4 or type 6 tympanoplasty, because it is safer, because there is lesser chance that the patient will end up with a postoperative intractable vertigo. So most of the times when there is a necessity for performing a type 5 tympanoplasty, it is always better to perform a type 3 tympanoplasty and allow the patient to use a hearing aid. Now coming to the types of type 1 tympanoplasty, this is very important and commonly asked in the exams as well. So according to graft placement, so this type of type 1 tympanoplasty, basically classification of type 1 tympanoplasty is according to the placement of graft. Now we know that the tympanic membrane is a tri-layer structure, so it has 3 layers. So this is your outer squamous layer, the middle fibrous layer, and the inner mucous layer. Now suppose this is the tri-layer structure and this is the part where the perforation is present. So we can place the graft in 3 types of ways. So the first type, when we place the graft above the squamous layer. So this is called overlay. Then we can place the graft below the mucosal layer. That is called underlay. And we can also place the graft between the fibrous layer and the mucous layer. So basically here. So if we place the graft between the fibrous layer and the mucous layer, it is called an interlay tympanoplasty. Now, amongst all these 3 types, overlay tympanoplasty has been shown to have the most chances of failure postoperatively. Interlay is the best technique if it is performed correctly, but since it is very difficult to perform and requires high skill from the surgeon's end, because separating the fibrous layer from the mucous layer is a very difficult job. So it is the safest way to go is the underlay technique. I wouldn't say it is the safest. If you can perform interlay tympanoplasty, it would be the best way. But since you require high skill and it takes number of years of practice to develop a proper technique to perform interlay tympanoplasty, so most of the surgeons go with underlay technique of tympanoplasty. So this is the types of type 1 tympanoplasty according to the placement of the graft. So now I'll explain why in the definition of tympanoplasty it was mentioned with or without the repair of the tympanic membrane. Now in type 1 and in some type 2 tympanoplasties only, we place the graft when the tympanic membrane remnant is present. The later types, that is type 3, 4, 5 and 6, even if the tympanic membrane remnant is present, we have to remove that, because those tympanoplasties are always combined with a mastoidectomy procedure, most commonly the canal wall down technique. It is basically you have to perform a canal wall down technique to perform a type 3, type 4, type 5, type 6 tympanoplasty. So in those cases, the tympanic membrane remnant is no longer present. So basically what we are placing as the graft acts as your new tympanic membrane. It is not a new tympanic membrane per se, it is only the graft that is present. So in those cases there is no repair of the tympanic membrane. We are placing a new graft. So only in type 1 and in few type 2 where we keep the remnant of the tympanic membrane, only in those cases we perform a repair of the tympanic membrane, that is myringoplasty. So in the definition of tympanoplasty it was mentioned that it is with or without repair of the tympanic membrane. So coming to the grafts that are used in tympanoplasty operation are the first one, which is the most widely used graft, is the temporalis fascia. The other materials that can be used as graft are perichondrium, tragal or conchal perichondrium may be taken, cartilage, again cartilage, tragal or conchal may be taken, fatty tissue, vein, subcutaneous tissue, fascia lata and skin. Now these are only the allogenous grafts. By allogenous I mean those grafts which have been taken from the same person on which we are performing tympanoplasty. Now in theory only, they are not commonly practiced, that is why I have not mentioned them in writing. We can use xenogenous grafts, like we can use bovine peritoneum, pericardium. These grafts can be used. Even nowadays synthetic materials are coming which can be used as a graft in tympanoplasty operation. But the temporalis fascia still remains the most widely used graft. And why is it so? Now there are certain advantages of temporalis fascia that it has over the other materials which are used as graft. So the temporalis fascia has a very low BMR. So what does that help us in? When we are placing it as a graft, there is a higher chance of survival, since as we all know, in a graft the blood supply has been compromised. So when it has been placed again, the uptake of the graft depends on how much metabolism or how much nutrients it is receiving. And since it has a very low BMR requirement, the uptake of the graft is way better than the others. And then another important thing is we can collect the temporalis fascia from a same incision of tympanoplasty. Like if we are performing tympanoplasty by the post-auricular approach in Weil's incision, we can extend it upwards to get a good amount of temporalis fascia with the same incision. So it has a cosmetic advantage. And then since temporalis fascia is hugely, the amount of temporalis fascia is huge, so even in revision surgery we can take temporalis fascia again as a graft. So it is abundantly present. And then temporalis fascia is, I mentioned, low BMR. So temporalis fascia, another advantage is that is again due to the low BMR, it can be like two pieces of temporalis fascia can be clubbed together. Still then there is a higher chance of uptake of the graft. And then another important thing about temporalis fascia is it can be used as both overlay and underlay as well as interlay grafts. So all of these makes the temporalis fascia amongst all the present graft materials was one of the best grafts to be used during tympanoplasty surgery. So coming to the goals of tympanoplasty, now this is basically a repetition of the definition only, but I have mentioned it separately to make you remember well. So coming to the goals, the first thing is eradication of disease. So irrespective of whether we can later on reconstruct the whole hearing process, we have to try our best to remove all the disease that is present in the middle ear cleft. Why is this important? Because suppose we are dealing with a case of cholesteatoma. Since it has a high chance of recurrence, it is always better to remove the disease than even if you have to compromise the hearing for that. So in certain cases, although it happens very rarely, the pre-operative hearing may be better than the post-operative hearing in certain cases of tympanoplasty. So in those cases, you have to counsel the patient very well, like after operation there may be a chance that what you are hearing currently may reduce. So that is why eradication of disease is the primary goal always and always. Then after complete eradication of disease, then only we come to reconstruction of hearing, whether it be by grafting on the tympanic membrane or placing a new graft or ossiculoplasty. Everything is secondary. By secondary, I am not saying it is not important, it is definitely important, but you always have to stress on the fact that tympanoplasty is primarily a disease eradication surgery. So coming to the indications of tympanoplasty. Now the indications include tympanic membrane perforation, which is associated with hearing loss with or without middle ear pathology such as tympanosclerosis, retraction pockets, and cholesteatoma. Now the important thing to mention over here is, suppose only a retraction pocket is present but there is no perforation, then also we have to perform a tympanoplasty. Now the contraindications of tympanoplasty. So they may be classified into absolute contraindications and relative contraindications. So the absolute contraindications are poor general condition of the patient. There is a malignant tumor involving the middle ear and the external ear. When there is uncontrolled cholesteatoma, in unusual infections like malignant otitis externa and the chronic otitis media, which has been associated with an intracranial complication like brain abscess, meningitis, lateral sinus thrombosis, etc. The relative contraindications include, these are more important than the absolute contraindications, because this is where the surgeon is in a dilemma whether they are going to perform the tympanoplasty operation or not. So suppose the year in which we are planning tympanoplasty is the better hearing year. What I mean by that is, suppose we are performing tympanoplasty of the right side, but the patient has a sensorineural hearing loss on his left side. Now in that case, while performing tympanoplasty of the right side, there is a chance that the patient might end up with a complication of tympanoplasty operation leading to irreversible hearing loss of that ear as well. So the patient has to live lifelong with hearing aid. So that is a relative contraindication. So the ear on which you are performing tympanoplasty is the only hearing ear or the significantly better hearing ear. Then coming to an acute exacerbation of a chronic otitis media. If we are performing a tympanoplasty operation when the patient is having an active infection in middle ear, there is a high chance of failure of that operation. So it is better to avoid tympanoplasty in those cases. First, it is better to control the indication with proper antibiotic and anti-inflammatory therapy. Then only we can proceed for
operation. In case of chronic otitis externa, it is better to avoid. But then again, if it is necessary, we have to perform tympanoplasty, and it is considered a relative contraindication further because we can treat the otitis externa before performing the tympanoplasty operation. And a non-functioning eustachian tube is also considered a relative contraindication for tympanoplasty. Now, I'll try to explain the step, the positioning of the patient and the uses of the instruments during tympanoplasty in a short video. And this video is only for the level of the third professional part 1 was student, because I won't go into the details of the instruments which are required for the proper middle ear work, only the commonly asked instruments.
So this video is showing uh, type 1 tympanoplasty by the post-auricular approach. So here the incision that has been made is the post-auricular Wild's incision, which is usually made 0.5 to 1 millimeter behind the post-auricular groove. Now after the initial incision and dissection of the subcutaneous tissue, this part is showing the harvestation of the temporalis fascia graft. So as we can see, the area of the temporalis fascia has been exposed, and we can see the attachment of the mollison's self-retaining hemostatic mastoid retractor. So as you can see, it is staying in place without the surgeon's effort. So it is self-retaining, so it is staying in place without the surgeon or the assistant having to hold the instrument. And it is hemostatic because, as you can see, it is creating a pressure on the edges of the incision, which is causing a pressure effect and reducing the bleeding from the edges of the incision. So it is hemostatic. So all in all, it is Mollison's self-retaining hemostatic mastoid retractor. Now as you can see, the temporalis fascia area has been exposed, and we are going to show you how the temporalis fascia is being collected. So as you can see, the surgeon is now exposing the area further. This procedure is called hydrodissection, where we place water between the temporalis fascia and the temporalis muscle, so that the temporalis fascia is separated from the muscle because of the pressure of the water. And now we'll make an incision for collection of the temporalis fascia graft. So as we can see, the temporalis fascia is almost separated from the muscle. In the meantime, let's talk about the position and the anesthesia in which the type 1 tympanoplasty is performed. Even other types of tympanoplasties can be performed, are performed like this only. Like see, the patient is in supine position with the head turned to the other side. She is being operated on her left ear, so her head will be turned towards the right side. So that is the position of the tympanoplasty operation. Now as you can see, it is being pointed out that the temporalis fascia is totally separate from the muscle. We basically have to take it up from the muscle. And the anesthesia used here, since this is an adult patient, we are doing it in local anesthesia. And in case of children, we have to go for general anesthesia. Now I am not showing anything that we do in the middle ear, because that is a little more difficult to understand in the UG level. So only the collection of the temporalis fascia has been shown.